Well, thank you very much for giving me the chance to talk. I'm actually a doctor at Adam Brooks, and I'm a clinical immunologist dealing with rare diseases in my day job. But more importantly, my family is affected by Dyskeratosis congenita. And I discovered this actually in 2014 when my father came unwell with a very unusual constellation of symptoms. And of course, I did what all great doctors do. I looked in Google and I came up with a diagnosis. But none of the doctors at the top hospitals I'd taken my father to, almost none of them had heard of it. There was no diagnosis. And it was all a bit of a problem. So I decided that actually we could do better. Now, what is Dyskeratosis congenita? So if you look at the background here, these are telomeres, and the little red dots at the end of the telomeres. So these are chromosomes, and the little red dots at the end of the chromosomes are telomeres, which are like the caps on a shoelace, and they've been stained red here. And when a cell divides, the telomeres get shorter, and when the telomeres are a certain shortness, that cell can't function anymore and dies. And as we age, all of our telomeres get shorter, and it's one of the main things that probably leads to aging. And if you have Dyskeratosis congenita, these telomeres shorten much more quickly, and people affected have a variety of unpleasant symptoms, but particularly bone marrow failure, lung fibrosis, liver fibrosis, and they tend to die early, usually in childhood or early adolescence. Now, it's said to be ultra rare, 1 in a million. I'm going to challenge that a little bit because I think most people who have this condition probably live and die without even a diagnosis. When I first found out that it wasn't just my father, it was many members of my family, I felt totally isolated. We didn't really know what to do. There was no help and support. There was actually no NHS diagnosis, there were no licensed treatments, and we couldn't get to the specialist multidisciplinary care we needed. We just had to go around to a selection of different specialists. And I'm sure this is a very familiar story for those of you having rare diseases. And so the first thing I did was I contacted other patients, and I couldn't find any in the UK, so I went to America, and I met the American patients. And actually they'd met in their meeting. It was very, very helpful for me. But actually people were sitting around saying, I remember one lady who said, well, we're just sitting around waiting for the next horrible thing to happen to our child. And I thought that was terrible. And actually I disagreed, because I think there's a lot of things that can potentially be done. And what it needs is a new attitude from the patients and the doctors. So we started DC Action. I'm just going to challenge, I don't think it is that rare. It's diagnosed in 1 in a million, but we do know that one gene variant that causes Dyskeratosis congenita is present in 1 in 100 Orthodox Ashkenazi Jews. And in fact, when I started looking, I began to see in my own patients a couple of people that I thought might be affected, and when I looked at their genetics, indeed they were affected, and that had huge implications for their management. We know that chest physicians aren't really just beginning to wake up to telomere problems, Dyskeratosis congenita. We know that pulmonary fibrosis is rare, but not that rare. And we know that a significant minority of those people will have a telomere problem underlying that. And ditto with bone marrow failure. The haematologists are probably the most switched on to Dyskeratosis congenita. No liver physician, apart from one that I've ever met, has ever heard of this. But there's a huge epidemic of cirrhosis of unknown cause and sort of pre-cirrhosis inflammatory liver conditions, which are exacerbated by lifestyle and fat and diabetes. But actually, I suspect that there's going to be a genetic cause for a proportion of those. And finally, we're an ageing population, so actually everyone should be interested in things which help telomeres. So firstly, how can we get diagnosis? Well, for my father, I discovered that at Queen Mary's, University of London, there's a professor called Diagnostic who was doing research into this condition. And I discovered there was a lab in Canada that would measure telomere length, which was one of the important diagnoses, as Hilary told me. So I sent off the genetics and the telomere length. The genetics were negative, and the telomere length was inconclusive. But actually, after my father's death, Prof. Dokel got back to me, and it turned out that he did, in fact, have a genetic variant causing the disease, and that was both the diagnosis. Now, I think things are going to be a lot better in the future. So we've got the 100,000 Genomes Project. In my day job, I can order gene panels, but under immunology. And this looks at most, but not all, of the genes we want. And if I get a positive on those genes, it comes out as severe combined immune deficiency, which is not the same as Dyskeratosis congenita. So actually, we're writing and trying to get panels just for Dyskeratosis congenita. This is not an extra piece of work. So then we're reaching out. So we've got to get everyone together. You can't have diagnosis without the physicians and the patients thinking maybe it's this. So we're meeting people individually, we're meeting patient groups, we're meeting the charities have been hugely helpful. This group here, CCC-TAA, is the American Association, largely American Association of Physicians, who I'm now a member of. And actually we're having our first UK physicians and scientists meeting. So if any of you know anyone who might be interested in that, they are very welcome. And the people we've met individually have been hugely enthusiastic. We've met basic scientists. We want to influence them. We think we have some drug candidates, so repurposing of drugs, and some maybe more fancy drugs that we think would be very effective. There's even a little bit of case report stuff. We're setting up a registry. We have no money at all, but the Sanger Centre here in Cambridge has lots of money. And we've got Prof. Dokal's biggest registry in the UK is in a filing cabinet on little bits of paper. It's now going into this wonderful register. And we're helping with actually the data input and everything. So, and then finally, we need a specialist clinic. And we need to be ambitious, but we need to be imaginative with that. These are actually the Americans, so these are the doctors, this is the Patients Association. They're a bit ahead of us, but actually not that far ahead of us. And then when we have that, we'll be all together, we can share knowledge, we can stand together, we'll be a group where we can participate in trials, and we can go to people and say, actually, here we are, we're an opportunity for you, let's push this field forward. I think that's it.